Hello friends and welcome back to PART-2 Pulmonology. Today is the part 2 of arterial blood gas analysis. Yesterday we had discussed the part 1. Hope you guys found it useful. So coming to the part 2 today, we will be discussing from step 5 to step 9 today. Coming to the step 5, that is how to identify the secondary disorder. Yesterday we had discussed how to identify the primary disorder by using the mnemonic ROME, correct? We identify the secondary disorder when the primary compensation is underadequate or overadequate, then the secondary disorder need to be suspected. Okay, don't get confused by this statement. I'll explain it with an example. Suppose in emergency department you get a case of acute exacerbation of COPD and you get an ABG. pH is 7.32, PCO2 is 60, bicarb is 40 and PaO2 is around 55. So see, the pH is in the acidic range because it is less than 7.35 and PCO2 is high. So both are in the opposite direction. So primary will be respiratory acidosis. Now you calculate for the compensation of the bicarb. See, COPD will cause chronic respiratory acidosis. So for every 10 mm rise in PCO2, the bicarb should rise by 4. So from 40, the PCO2 is 60. So 20. So for every 10, if it is rising by 4, for 20 it should rise by 8. So 24 plus 8 should be 32. But in our ABG, the bicarb is 40. So it is high. Means there is associated secondary metabolic alkalosis. So this is how you identify the cases of secondary disorder. This is one example. Coming next, how to calculate the anion gap. Anion gap is calculated in cases of metabolic acidosis. Anion gap is equal to the serum sodium minus chloride minus bicarb of or sodium minus in total of chloride plus bicarb. Normal value is 8 to 12 or 10 plus or minus 12. If it is in the normal range, we call it as normal anion gap metabolic acidosis. If it is more than 12, the anion gap, we call it as high anion gap metabolic acidosis, also known as HAGMA. Okay. So what are the causes of HAGMA? We remember it by a very old age pneumonia, that is mud piles. M is for methanol poisoning, uremia, diabetic ketoacidosis, phenorphin, paraldehyde, isoniazid, iron, lactic acidosis, ethanol, ethylene glycol or salicylate. Okay. Causes of NAGMA by mnemonic hard-ups, hyperalimentation, acetozolamide use, RTA, type 1, type 2 and type 4, diarrhea, uretrosigmoid fistula and pancreatic fistula. These are the causes of NAGMA. So once you identify metabolic acidosis, you calculate the anion gap and you differentiate between HAGMA and NAGMA. In all cases of NAGMA, you need to calculate the delta gap. So what is delta gap? Delta gap is equal to anion gap minus 10 by 24 minus bicarb. I had shown in the previous slide how to calculate the anion gap. Whatever value you get, you substitute here and divide it by 24 minus bicarb. Where bicarb will be given in ABG. If it is the values between 1 to 2, it is pure HAGMA. If it is less than 1, it will be HAGMA plus NAGMA. If it is more than 2, it will be associated metabolic alkalosis. Okay, remember that is delta gap is calculated in cases of metabolic, in case of high ionic gap metabolic acidosis. Okay, osmolar gap. In some cases of unexplained HAGMA, okay, in some cases of unexplained HAGMA, we calculate osmolar gap. What is osmolar gap? It is measured osmolality minus calculated osmolality. So measured osmolality is identified based on the serum osmolality. If you draw a blood and send it to the lab, they give you the serum osmolality. That you have to subtract from the calculated osmolality. Calculated osmolality is given by 2 into serum sodium plus glucose plus urea. Okay. When you subtract these two, you get the value. The normal value is less than 50 microosmolar per liter. If it is more than 15, we call it as high osmolar gap, which indicates the presence of toxic alcohols like methanol and ethanol. Okay, remember in cases of HAGMA, we calculate two things. What is that? We calculate delta gap and we calculate osmolar gap. Okay. Now coming to urinary anion gap. Urinary anion gap is calculated mainly in the normal anion gap metabolic acidosis. So how do you calculate it? We calculate it by urinary anion gap is equal to urinary sodium plus potassium minus chloride. If it is positive, that is if it is more than 0, it is type 1 and type 4 RTA. If it is negative, it is because of diarrhea, hyperuricemia or sodium infusion. Okay, urinary anion gap in cases of NAGMA. Coming to the use of calculating urinary chloride in cases of metabolic alkalosis. Suppose whether the metabolic alkalosis is fluid responsive or no. How do we come to know? If we calculate the urinary chloride, if it is low, then the metabolic alkalosis is fluid responsive. Suppose the patient has lot of vomiting, means there will be lot of vomiting, there will be loss of H plus, so that will lead to alkalosis. So such patients, the urinary chloride will be low because the body will try to reabsorb all the electrolyte like sodium, bicarb and chloride. Okay, so in such cases, by giving fluid, the metabolic alkalosis will improve. Okay, remember this, urinary chloride is calculated mainly in cases of metabolic alkalosis. Come to the last step, that is to identify the hypoxia. Hypoxia is defined by PaO2 of less than 80 mmHg on room air. Again, we have various mechanism for hypoxia, so that we differentiate by calculating alveolar and arterial gradient. So what is this gradient? We calculate the alveolar uh, partial pressure and we subtract it from the partial pressure of the arterial blood gas of oxygen. So whatever the value we get, we call it as an alveolar arterial gradient. So how do we do this? I will make a separate video on this and I will let you know. Okay, for now remember, whenever you interpret an ABG, it is also important to interpret how to identify hypoxia. Okay, so these are the total 2 videos of how to interpret an ABG. Today yesterday was part 1, today is part 2. If you have any doubt, please leave it in the comment box. I'll be very glad to answer. Okay, if you have any doubt, please leave it in the comment box. Okay, thank you all for your patience listening. Thank you.